Dear friends, happy World Health Day and welcome to day 2 of the OncoAlert Spotlight Forum. We developed this forum as a yearly follow-up to the OncoAlert Colloquium to place our focus in areas where there is an unmet need and to let us know how oncology is in the entirety of the world. Today, we celebrate World Health Day. Our amazing OncoAlert faculty has compiled a series of presentations on the advances in specific tumor groups. The findings we will discuss today give us hope and make us optimistic of a future without cancer. We thank you for all your support and for your part in making the world a healthier place. Without further delay, day 2 of the Spotlight Forum.
My name is John Hane. I'm a medical oncologist working at the Netherlands Cancer Institute in Amsterdam. Let me tell you about immunotherapy, a major breakthrough in cancer treatment. Our body has been equipped with an immune system that should protect us against foreign intruders, like harmful bacteria, but also viruses. Think about the current coronavirus pandemic, to which the world population has no natural defenses. Hence, we have started a massive vaccination campaign to help the immune system fight this virus. But we also learned over the past decades that an immune system can help also fight cancer. Cancer is a disease caused by DNA damage. And for instance, by smoking, we inhale chemicals that can lead to DNA damage of lung cells and therefore cause, in some patients, lung cancer. Exposure to sun means also exposure to UV radiation, which can give DNA damage of skin cells and, in some patients, the development of skin cancer, like, for instance, melanoma. Researchers have carefully examined the amount of mutation over many different cancer types. You can see in this graph that melanoma and lung cancer are completely to the right, meaning that on average, they have the highest number of mutations of all cancers. We've learned that the more DNA damage, the higher the chance that the immune system can see the cancer like they can see a virus-infected cells. However, the immune system is also equipped with natural brakes that protect the attack of normal cells, and cancer cells still look very much like normal cells. Therefore, immunotherapies have been developed that take away these natural brakes on the immune system to really unleash its full power to attack the cancer. These drugs are called immune checkpoint blockers. Examples are ipilimumab, nivolumab, pembrolizumab, atezolizumab, and so forth. These drugs are most active in cancers with a lot of DNA damage. Here you see an example. Improvement in 3-year survival of patients with melanoma treated in clinical trials with immune checkpoint blockade. Prior to 2010, patients were treated with chemotherapy that had hardly, if any, effect on survival. With the introduction of ipilimumab and later in 2015, pembrolizumab and nivolumab, or the combination, there's a substantial increase in survival of these patients. But also on real-world treated patients, we see an increase in survival. These are data coming from the Dutch registry, where patients were treated with metastatic melanoma in 2012, 13, 14, and 15. You can see that over the years, the survival of these patients was improving. We are now moving immunotherapy to earlier stages of disease, and we see that the treatment is even more effective there. For patients with locally advanced melanoma, of whom about 50% are cured by surgery alone, post-surgery treatment, adjuvant treatment with nivolumab and pembrolizumab for 1 year has become standard of care, as it gives a reduction in the chance of the disease coming back of about 20%. Still experimental, but even more interesting, is a short duration of immune checkpoint blockade prior to surgery. For 6 weeks, ipilimumab plus nivolumab results in over 60% of patients in a reduction of disease of 50 to 100% at surgery. The survival of these patients turns out to be excellent. But not only for melanoma, immune checkpoint blockade has been approved. It was the first disease. But you can see over in the past years, immune checkpoint blockade has become standard of care for lung cancer patients, for renal cell cancer patients, bladder cancer patients, head and neck cancer patients, colorectal cancer patients, breast cancer patients, non-Hodgkin's lymphoma, cervical cancer patients, etc. This list is only growing. It's my belief and expectation that in the 5 years to come, we will see many, many new and important breakthroughs with immunotherapy. I thank you for listening.
Hello, everyone. On this World Health Day, I will talk about breast cancer breakthroughs. I am Bhavna Sirohi. I am a breast medical oncologist at Apollo Proton Cancer Center in Chennai. This is the outline of my talk. Breast cancer, as you can see, is one of the commonest cancer in women globally. 1 in 4 cancer cases is diagnosed with breast cancer, and 1 in 6 cancer-related deaths is due to breast cancer. 2.3 million new cancer cases are diagnosed every year. We have become very good at treating breast cancer with improvements in 5-year survival, as can be seen from the Concord data and from the SEER data, that the 5-year survival is as high as 94% in hormone receptor positive breast cancer. And as per the Concord data, in some countries, it's more than 90%. Looking at de-escalation or optimization in early breast cancer, our surgical colleagues have become very good at de-escalating the axilla especially and breast conserving surgery. And radiation dosing has been mainly hypofractionation, which can be delivered in 1 dose within 1 week or 3 weeks of radiation. Use of deep inspiration breath holding for left-sided breast cancers has decreased the dose to the heart, which is very important, as with patients living longer, the cardiotoxicity becomes an issue. As far as systemic treatment is concerned, we omit 5-FU from chemotherapy regimens as it only adds to toxicity. The phase 2 APT trial with just 3 months of chemotherapy in selected patients with HER2 positive breast cancer, mainly stage 1, showed that the 5-year, that the long-term outcome, the 7-year survival was as high as 95%. The Persephone trial de-escalated to 6 months of adjuvant trastuzumab, being non-inferior to 1 year of trastuzumab. The TAILORx and MINDECT studies have actually shown us that the genomic signatures can help us spare chemotherapy in almost 50 to 60% of patients. As far as endocrine treatment is concerned, a lot of work is being done in using low dose of tamoxifen like in DCIS, and also looking at the drop in Ki67 at 2 weeks after diagnosis to see if we can forego chemotherapy in some patients. Predicting late recurrences so that we don't have to give 10 years of endocrine treatment to all patients is also something which is being done as with the CTS5 score and the Regan score. Looking at the advanced breast cancers, in hormone receptor positive advanced breast cancer, even with visceral crisis, with the use of CDK4/6 inhibitors and endocrine treatment, one can delay chemotherapy to a total period of up to 3 to 4 years in selected patients. And the space is becoming more and more exciting with the use of PIK3CA inhibitors like alpelisib and various other drugs which are in pipeline. The HER2 receptor positive advanced breast cancer is again very effective treatments available with first line with docetaxel, trastuzumab, pertuzumab, and TDM1 in second line, and third line trastuzumab, deruxtecan, with the survival, median overall survival crossing 5 years, which is very exciting. As far as triple negative breast cancer is concerned, clear progress has been made in androgen receptors, PI3K, AKT pathway, the DNA damage repair, and immunotherapy space also looks exciting. Third line sacituzumab govitecan has been approved in triple negative breast cancer with a median overall survival of 12 months, which is very promising. The future directions, we need to address the key challenges, mainly the disparities in cancer care, especially globally, geographically, economically, and racially. We need to develop better drugs which are meaningful to patients. We need to de-escalate without compromising outcomes, especially whether we can select patients in whom we can avoid anti-HER2 treatment completely. Can we use Ki-67 to avoid post-op adjuvant chemotherapy, because not most of our patients can afford the genomic signatures? And also whether we can avoid surgery in patients who've had a complete clinical response to neoadjuvant treatment. We also need to be able to effectively address issues of cost and sustainability of these treatments that we are recommending. The breast cancer mortality rate is much higher than that of COVID-19 infection, so we must continue the usual care if we have to continue to improve outcomes and vaccinate all breast cancer patients at all stages of their breast cancer journey. Thank you.
My name is Axel Grothe. I'm a GI medical oncologist at Breast Cancer Center and Research Institute in Germantown, Tennessee. And I'm very honored to talk about GI oncology and updates and the positive aspects of GI oncology for the OncoAlert Spotlight Forum in honor of World Health Day. It's one of my favorite topics to talk about, all the advances we've made to improve patient care. And I want to highlight this in 3 different points. Moving immunotherapy into earlier lines of therapy, which has really made a big impact in common malignancies, establishing comprehensive molecular profiling as standard of care with consequences for therapy, and harnessing the power of ctDNA for treatment decisions. Now, moving immunotherapy into earlier lines of treatment has particularly happened recently in upper GI malignancies, esophageal and gastroesophageal cancers, squamous cell cancers, and adenocarcinomas. Hepatocellular carcinoma saw the inclusion of atezolizumab-based treatment in first line. In particular, colorectal cancer, also pembrolizumab for MSI high, mismatch hepatoefficient, very immunogenic cancers. And I believe that some of these cancers can actually move into a kind of a long-term, no evidence of disease state just with chemotherapy up front. So we can even potentially think about a curative approach for stage 4 cancers. This will require a longer follow-up, but the power of immunotherapy moving into earlier lines of therapy, and then as a next step, hopefully in the adjuvant setting to cure more patients early on, is clearly something that has changed our approach for these malignancies. The second point is establishing comprehensive molecular profiling as standard of care, because it has treatment consequences. We're moving patients into targeted treatment options in various GI malignancies. We have a spectrum of positive and negative predictive markers, and in particular, the biliary cancers, intrahepatic cholangiocarcinomas are very rich in potentially targetable alterations. So we're moving a patient population with a very poor outcome, cholangiocarcinomas, into something that is more treatable, still not curable in advanced stage, but definitely better treatable with targeted approaches. And this is really encouraging for patient population that had really been left behind with systemic treatment options for a long time. The third point and last point I want to talk about is ctDNA, circulating tumor DNA, which really is transforming and changing the way we approach cancer, from using ctDNA for diagnosis, screening even. Think about a blood draw a year in lieu of all these screening approaches, pap smears, colonoscopies, etc., that we're doing just to detect early precancerous lesions, even with circulating tumor DNA. Then, of course, minimal residual disease, the holy grail of adjuvant therapy, to identify patients who really need adjuvant treatment and not use adjuvant treatment in patients who do not need it, or treat patients where we normally do not treat when we see that ctDNA is positive after curative resection. So this is currently already changing the way we approach adjuvant therapy. We can use ctDNA for treatment response, the perfect tumor marker, really, and as a kind of a shedding mechanism of tumor cells that we can detect in patients' blood, not as crude as CEA and CA19-9 as old tumor markers. And we can actually sequentially, longitudinally look for markers of acquired resistance using the power of ctDNA. So we are transforming oncology. It's a very exciting time. We are seeing improvements in outcomes. We are seeing a select patient population that have great benefit from our targeted approaches, immunotherapy approaches. I've never been more excited to be a GI oncologist than at this point in time. So great for the World Health Day. We've made a lot of advances.
Hello, everyone. I'm Vanita Narona. I'm a medical oncologist at Tata Memorial Hospital in Mumbai, India. It is my privilege today to briefly speak on the advances in lung cancer that we have noted recently. This will be the outline of my talk. I'll discuss the decline in lung cancer mortality, advances in the fields of prevention, therapy, testing facilities, and improvements in quality of life. So starting with the decline in lung cancer mortality, lung cancer continues to be a very, very important health problem worldwide. In the USA in 2021, lung cancer continues to be the second most common cause of cancer in men and women, accounting for 12% of the new cancers in men and 13% in women. It continues to be the leading cause of cancer mortality. It accounts for 22% of cancer deaths in men and 22% in women in USA in 2021. The lifetime risk of developing lung cancer varies based on the age of the person. Overall, from birth to death in men, the chance of developing lung cancer is 1 in 15, and in women, it's 1 in 17. However, the trends in cancer incidence are heartening. Overall, the cancer incidence rates have dropped by a 20% drop in men and 2% in women. And this drop overall in cancer incidence has largely been driven by a decrease in the incidence of lung cancers. The trends in cancer deaths are equally heartening. There has been a decline in mortality for lung cancer, which has recently accelerated. Between 2014 and 2018, the annual decline in the death rate from lung cancer doubled from 3% to 5.5% in men and from 1.8% to 4.4% in women. So the overall drop was a doubling of the decrease in the lung cancer mortality. So from 2.4% to 5%. And lung cancer was responsible for almost half of the total decline in cancer mortality. The death rate from lung cancer dropped from its peak in the 1990s to a decrease of 54% in men and 30% in women. Take a look at this section in the center. This is the 5-year mortality relative survival for a patient with lung cancer. The 5-year survival currently for a patient with localized cancer is 59%, and overall the 5-year survival is 21%. Of note, the majority of patients have advanced lung cancer. So there's a 21% survival at 5 years for all stages of lung cancer. The 2-year survival, the relative survival for lung cancer has increased from 30% in 2009 to 2010 to 36% in 2015 to 16. And this has again largely been driven by an improvement in relative survival for non-small cell lung cancer, which increased from 34% to 42%. The 2-year relative survival for non-small cell lung cancer had an absolute increase of 5 to 6% per stage. Coming to prevention, we have made great strides in prevention, and we are very grateful for multiple political activisms that have led to all these warnings on cigarette smoking. Cigarette smoking has consequently declined. In 2005, 21% of persons overall were smokers, while in 2019, 14% are smokers. Several randomized trials have proven the role of screening for lung cancer, and therefore lung cancer screening is now standard for any person who has a 20-pack-year smoking history, who is currently smoking or has quit smoking in the last 15 years and is aged between 50 to 80 years. Coming to therapies, multiple therapeutic advances have occurred in the field of lung cancer. Starting from the adjuvant setting, the ADAURA trial created great waves. In patients with epidermal growth factor receptor mutant non-small cell lung cancer who have undergone curative intent surgery, 3 years of adjuvant osimertinib led to a marked, significantly prolonged improvement in disease-free survival as well as in overall survival. In patients with locally advanced lung cancer, the PACIFIC trial showed us that the addition of immunotherapy of durvalumab after a patient has received definitive chemoradiotherapy led again to a marked and durable improvement in overall survival and progression-free survival. In advanced lung cancers, in almost every phase of, in every stage of advanced non-small cell lung cancer, we have seen improvements, starting from patients with oligometastatic non-small cell lung cancer, patients, the introduction of consolidation therapy versus continuing maintenance or observation therapy has led to an improvement in disease-free and overall survival. Multiple molecular targets have been discovered and multiple therapies have been developed and approved to target these specific molecular targets. The most common are EGFR and ALK, but many other molecular targets have recently come into the clinic with therapies that can specifically target these diseases. The two most common molecular targets are EGFR and ALK. On the left side, you have the FLORA study in which patients with osimertinib treated for advanced lung cancer had a median overall survival of 38.6 months and a 2-year overall survival of 74%. In the ALEX study, patients treated with alectinib did not attain, the median overall survival was not attained, but the 5-year overall survival was 62.5%. Now keep in mind, these are all patients with advanced metastatic non-small cell lung cancer. Immunotherapy has changed the face of lung cancer therapy. In the first-line setting, the combination of pembrolizumab and chemotherapy led to a median overall survival of 22 months, and the 24-month survival was 45.5%. In patients who had a PD-L1 greater than 50%, the 2-year overall survival is in excess of 50%. In the relapse setting as well, patients treated with pembrolizumab had a median overall survival of 16.9 months and a 3-year survival of 34.5%. In terms of testing, liquid biopsy is making great waves. It is a nice non-invasive method to get to the tumor, to capture spatial as well as temporal tumor heterogeneity. And patients are not just living longer, but living better lives. Patients with advanced lung cancer, the introduction of early palliative care has improved the quality of life, improved their mood, led to the use of less aggressive care at the end of life, as well as prolonging survival. So the bottom line is lung cancer incidence has decreased. We have more and better therapies currently. Survival is longer and patients are living better. Science and research does save lives. Thank you.
Hello. I'd like to start off with thanking OncoAlert for the opportunity to give a high-level overview, shine the spotlight on recent advances in radiation oncology and what the future may hold. And thank you for tuning in. As you know, approximately half of all cancer patients receive radiation therapy at some point in their lifetimes. Radiation can be curative. It can be used to palliate symptoms. It can control disease without curing. And it can also synergize with systemic therapies in a way where it may not necessarily do any of the other three things. Radiation can be modified through physical and biological means to achieve these effects, while at the same time minimizing any injury to the normal tissues that surround a radiated tumor. The components to achieve these are technical precision, as illustrated here, and an understanding of how radiation damages cells on a molecular level, how we dose tumors and normal tissues, how we break up the dose into small fractions every day, and how we distribute radiation over time. With this foundation, the last few years have seen tremendous progress in radiation advances in most, if not all, cancer types. Some examples are shown here. There's not enough time in 5 minutes to go into any kind of detail here. But I think if you take a step back, I think there's some trends you can clearly see. For example, radiation is more often used in an ablative fashion, high doses that have special biological effects on the tumor. Radiation is becoming increasingly image-guided, PET, MRI, which helps to pinpoint high doses at the tumor, and again, spare normal tissues around the tumor. Radiation courses are becoming increasingly shorter, which is good. It's more convenient for patients. It's less expensive. And generally, modern radiation is associated with much less toxicity than it used to be. And there are a lot of ways, technological and biological means to make this happen. But perhaps the greatest achievement in the last few years in our field is the increasing recognition that radiation has immune modulatory effects, where it can, for example, improve tumor antigen presentation or promote cross-priming of T cells, and really combinations of radiation with immune checkpoint inhibitors are being studied in virtually every cancer type, and there's great promise, and we're all very excited to see what the next few years will bring. Which brings us to the question of, well, where are the next advances are gonna come? Radiation has always defined itself as or defined itself through technological innovation and advances, as illustrated here on the left. But have we perhaps reached a plateau where even further advances may only yield small improvements in tumor control or toxicity reduction? And I think it's increasingly clear that to really move the needle, we will need to advance our understanding of the biological effects of radiation. That will be the next frontier. In fact, it's already upon us. As I mentioned, radiation, the immuno-oncology space for sure. Increasingly, precision medicine concepts are introduced into clinical trials and will reach clinical practice at some point, which means biomarker-guided radiation therapy, which means more drug combination approaches. Clearly, we will gain a better understanding of the biology of high POF fractionation, which is the use of higher doses than standard, for example, ablative doses. We will need to learn more about the biology of particle radiation. There's the flash radiation, very timely and very exciting. So all of these things will happen. And at the same time, targeted therapies and immunotherapies will continue to deliver breakthroughs for patients with cancer. But I'm confident that radiation may always be needed to non-invasively eradicate the last surviving drug-resistant, immune-escaped, and dormant cancer stem cell that otherwise would lead to recurrence. And with that, thank you for listening. And again, thank you to OncoAlert.
Hello, my name is Dorothy Keefe, and I am speaking today on behalf of the Multinational Association of Supportive Care in Cancer, or MASC. I'd like to start by thanking the organisers for inviting me to give this talk and to explain that I have no conflict of interest. I would also like to acknowledge the traditional owners of the lands from which I'm presenting today, the Eora Nation of the Gadigal people in Australia. I'll start with a little bit of history about supportive care in cancer. Obviously, the ability to successfully treat cancer itself was a huge breakthrough, but at the start, patients had to suffer for their cure because there was no way to manage their side effects. Side effect management has always lagged slightly behind cancer treatment, sometimes a great deal behind. But science is science, and we can use the same techniques, and we should use the same techniques to treat the cancer as to treat the toxicity, making sure that the cancer treatment is not compromised. And there is obviously more to supportive care than toxicity management. It includes physical and psychological impacts of cancer and its treatment, rehabilitation right the way through treatment to survival or end-of-life care. And it does include the financial and the spiritual domains. MASK is made up of multiple study groups. I've just highlighted a few of them here that I'll talk about more later, but in fact, there have been advances in all of these areas that we're unable to cover today due to time constraints. So what are the big advances? In Antiometics, it was the introduction of the 5-HT3 antagonist, which enabled chemotherapy to be given as an outpatient. The later introduction of NK1 inhibitors and combinations of these drugs, along with the optimal use of the already available drugs such as dexamethasone and metoclopramide, allowed much better care for emesis and to a certain extent, also nausea. Olanzapine has had good impact in this area too more recently. MASK produces guidelines on a regular basis for the management of antiemetics and also has an anti-emesis tool on an app. With febrile neutropenia, many patients would die from this in the early days before the days of GCSF. The introduction of pegylated GCF and the once per cycle dosing again made this a much more convenient treatment. Antibiotic combinations have helped, and the MASK febrile neutropenia tool enables us to predict whether a patient will be able to have their treatment for their febrile neutropenia safely as an outpatient. In mucositis, we've been producing guidelines for the last 20 years and sadly haven't really been able to obliterate the problem. The use of palifermin is very effective in stem cell transplant, and ice chips are very good for short plasma half-life drugs, but a new paradigm shift is needed in order to overcome this big problem. The development of targeted therapies meant we needed to have new toxicity management. Skin toxicity is a very big problem with targeted therapy, and the introduction of the EGFR inhibitor skin toxicity tool by the MASK Oncodermatology group has been a great step forward. The biggest thing in cancer, as well as in supportive care recently, has been the introduction of immunotherapy. Managing the immunotherapy toxicities has meant that medical oncologists have needed to become more generalized than they have been for multiple decades. We need to have skill and expertise and know when to call for help from respiratory, cardiology, neurology, endocrinology, rheumatology, and other specialties. Geriatric oncology has made great strides, enabling more older people to engage in clinical trials, which means that we have a better understanding of whether drugs actually work in the older population safely. And screening for frailty has helped us to avoid treating patients for whom treatment is not the best way forward. The emerging areas in supportive care remain financial toxicity, survivorship care, and even the prescription of exercise, as well as how we manage the rare but life-threatening side effects of CAR-T toxicity. The biggest changes, however, are in how we think about supportive care. When I started in oncology, it was a fringe area, and it is now central to the management of all cancer patients. Patient-centered care, with joined-up care as part of a defined model of care, produces the best outcomes. Using all the technology available to enable care allows us to free up the time that's needed by the clinicians to spend the vital times with the patient when only a face-to-face and human touch consultation will do. We need to make sure that we're using all the tools of science to their full scope in supportive care as well as in cancer treatment, targeting therapy and targeting toxicity management. And because every new class of drugs brings a need for new supportive care interventions, we're never going to be out of work. Optimizing supportive care is a really important issue. When we listen to the patient, when we do all the things we already know how to do, when we join up care properly, when we tailor both treatment and toxicity management, and when we think of other issues outside of the cancer, such as out-of-pocket costs, travel, comorbidity, belief systems, origins, families and communities, and work situations, the patient has a better time in treatment and a better outcome from their cancer. I'd like to leave you with MASK's motto, which sums it all up really, and that is that supportive care makes excellent cancer care possible. Thank you.
Hi, I'm Ravi Kaneswaran. I'm a medical oncologist at the National Cancer Center Singapore. I'm also currently the president of the International Society of Geriatric Oncology, SIOC. It gives me great pleasure to share with you as part of the Spotlight Forum series about geriatric oncology, and I would like to thank the organizers, OncoAlert, for this kind invitation. A brief outline of what I'm going to talk about, some recent statistics about geriatric oncology, key public policy initiatives, and I'll summarize. The number of persons aged 65 years and older is going to increase rapidly over the next 30 years. As you can see here, it's going to increase from about 702 million people in 2019 to more than double that number of 1.5 billion people aged 65 years and older in 2050. And based on these estimates, a lot of that increase is going to come from developing countries in Africa, many parts of Asia, and Latin America. As you can see here, cancer is a disease of aging. In males, more than 70% of cancer patients, and this data from the United States, more than 70% of cancer patients are aged 60 years and older. And more than 60% of cancer patients, female cancer patients, are aged 60 years and older. Underlying that, age is a major contributing factor for cancer amongst older adults. Now, the history of cancer and aging dates back right to the formation of the National Institutes of Health in the US. And of course, there have been small developments along the way until, of course, a key milestone, which happened in 1983, when the first NIH conference on cancer in the elderly was convened under the direction of Dr. Rosemary Yanchik and Dr. Paul Carbone. And since then, there have been many inroads made by many oncologists in this area, as you can see highlighted in this nicely drawn diagram, which you can refer back to at the ASCO Post 2020, sometime in October last year. Some of the key milestones included the fact that NCCN initiated a committee on cancer and aging back in 1998. And of course, since then, as you are probably aware, NCCN publishes guidelines for cancer in older adults. And all this culminated with the development and the formation of SIOC in year 2000. Here I also highlight the speech by the then president of ASCO in 1988, highlighting the importance of geriatric oncology in treating our cancer population, or at least the cancer population in the US at that point in time. So from the initiation or the formation of SIOC, it has grown from strength to strength. We have over 1,700 members from 80 countries, and it's involved in many facets of geriatric oncology, including education, research, and collaborations. So these are some of the many collaborations and some of the key courses that SIOC organizes, including advanced courses, not just in Europe, but outside of Europe as well. Geriatric oncology initiatives have now gone global. Not just in US and Canada, where these programs are very mature. There are fellowship programs for oncologists to specialize in geriatrics, in dual specialty training, and multidisciplinary groups being formed both on both sides of the Atlantic. More recently, we're seeing development even in developing countries in Latin America, with a lot of these geriatric oncology clinics being formed in countries like Brazil, Mexico. There are countries in Asia that have similar multidisciplinary clinics as well, not forgetting Australia, where this field has taken a foothold for a few decades now. Next, I would like to discuss a major challenge facing geriatric oncology. Clearly, clinical trials is an area where we still have much to do for our older population. On the left is a study published in 1999 showing that although 63% of the US cancer population was 65 years and older, only about a quarter of them were enrolled in SWOG studies. Now, fast forward 2001 to 2011, clearly this bar chart here highlights the need for emphasis about the enrollment of older patients with cancer. Again, not much of an improvement from 25% pre-2000 to about 28% of cancer patients being older than 65 enrolled from 2001 to 2011. So there's much to be done. And how are we meeting these challenges? So the SIOC Priorities Initiative, first published in 2010, 2011 by Dr. Martin Exterman, just received a rehash and improvement with the SIOP priorities now numbering 12, focusing on 4 key areas: education, clinical practice, research, collaborations, and partnership. So clinical trials is one of those areas, priority number 7, as you can see, but there are many, many areas where SIOP feels there's so much that we can do. And this public policy document actually provides some guidance for oncologists all over the world to step up and do more for our older patients with cancer. So in summary, the global population is seeing its most rapid growth in the older adult segment. Cancer is a disease of aging. Geriatric oncology was created out of the necessity to address cancer in older adults. SIOG is leading the way in promoting these geriatric oncology principles. And public policy initiatives and new collaborations recently have expanded the reach of SIOG to many parts of the world in order to address challenges afflicting older adults with cancer. Thank you very much.
This is Angerda Eriksson from the Norwegian Radium Hospital in Oslo, Norway. I'm grateful to Dr. Gil Morgan and the OncoAlert Network for this opportunity to highlight gynecologic cancers for World Health Day 2021. We'll highlight cervical, endometrial, and ovarian cancer, focusing on the incidence and outcomes, diagnostic and therapeutic milestones, as well as future directions to further improve the care for women with GYN cancers. Now let's start with cervical cancer. Cervical cancer is the 4th most common cancer in women globally, with just over 600,000 new cases in 2020. Approximately 90% of new cases and deaths occur in low and middle income countries, where cervical cancer is the most common gynecologic malignancy. Nearly a century ago, Dr. Papanicolaou discovered that cervical cancer cells can be detected by examining cells from the vagina under a microscope. The development of the Pap smear test is now recognized as one of the most significant advances in the control of cancer in the 20th century. In 1984, Dr. Serhausen established a link between human papillomavirus infection and cervical carcinogenesis. This is a finding that earned him the Nobel Prize 25 years later and has led to the development of HPV vaccines, with a potential not only to prevent precancerous cervical lesions, but also cervical cancer. In regards to therapeutics, bevacizumab was the first targeted agent found to improve surgical cancer survival rates. And although not listed on this slide, we've also seen some promising results in phase 2 trials with checkpoint inhibitors in women with cervical cancer in recent years. In high-income countries, we have seen improved survival across all stages of cervical cancer over the last decades. This is in part due to improved imaging as well as improved delivery of chemoradiotherapy. However, the most significant contribution has been made by implementation of organized cervical cancer screening programs and most recently HPV vaccination. Women who participate in cervical screening programs, they reduce their risk of developing cervical cancer by more than 80%. And those who do develop cervical cancer despite regular screening, they have better survival outcomes since their disease is detected at an earlier stage. Now, although there are a large number of ongoing clinical trials on targeted therapies in advanced stage and recurrent cervical cancer, and we do eagerly await the results, the highest potential in limiting the global burden of cervical cancer is implementation of widespread screening and vaccination. Now, moving along to endometrial cancer. Endometrial cancer is the 6th most common cancer in women with just over 400,000 new cases in 2020, and it's the most common gynecologic cancer in high-income countries. The majority of these cases are diagnosed at an early stage and are cured by surgery alone. The incidence of endometrial cancer is rising by approximately 1% per year, and slightly simplified, this increase is thought to be due to obesity and advanced age. In 2013, the Cancer Genome Atlas Research Network published the discovery of 4 distinct molecular groups of endometrial cancer with corresponding prognostically distinct subgroups. This has been a major milestone in understanding endometrial cancer. And the characterization of endometrial cancer subtypes also guides further development of targeted therapies with promising results. This pie chart shows that more than 24,000 cases of endometrial cancer could have been prevented in 2012 if the population BMI had remained constant the last 20 years. This illustrates the potential of preventing endometrial cancer by reducing obesity. Although there have been great advances in endometrial cancer diagnostics and treatment the past few years, there's a lot that remains as we continue to refine our understanding and also treatment of the disease. We need to identify better biomarkers so that we can guide personalized therapy, as well as explore combination regimens for targeted therapeutics, hormonal therapy, and immunotherapy. We do hope that these efforts, together with strategies to reduce obesity, will ultimately decrease the impact of endometrial cancer on women's health globally. Finally, we'll look at ovarian cancer. Ovarian cancer is the 7th most common cancer in women, with just over 300,000 new cases in 2020. It's the 3rd most common gynecologic malignancy and the most lethal worldwide. There is no screening test for ovarian cancer, so the majority of cases are diagnosed at an advanced stage, requiring extensive cytoreductive surgery and adjuvant chemotherapy. The introduction of platinum in 1976 and then of paclitaxel in 1993 were major milestones in the medical treatment of ovarian cancer. And carboplatin and paclitaxel have been the backbone of chemotherapy in ovarian cancer for half a century. Over the latter decades, we've also seen a change in the surgical approach to ovarian cancer, with an increasing surgical complexity and radicality, achieving complete cytoreduction. And this has led to a subsequent improved survival and prolonged time to recurrence in women with advanced ovarian cancer. Over the last decade, several trials have demonstrated improved outcomes in the recurrent and primary setting when adding bevacizumab or a PARP inhibitor to a chemotherapy regimen. This has been a very welcomed addition to the armamentarium of therapeutics we have in treating women with advanced and recurrent ovarian cancer. This is a very exciting time to be both a clinician and researcher working with ovarian cancer. There are ongoing efforts to explore reducing mortality through screening by understanding an individual's risk and subsequently offering risk-reducing surgery to high-risk women. Identifying the optimal sequencing of surgery and chemotherapy for the individual patient, and exploring if there are biomarkers to guide a personalized approach to surgery, as well as the role of HIPEC, ultra-radical surgery, and minimal invasive surgery are also areas of great interest. We continue to explore combination regimens for VEGF inhibitors, PARP inhibitors, and immunotherapy. Adaptive cell immunotherapy using CAR T cells in ovarian cancer is a promising treatment approach. And there are also ongoing studies investigating various antibody-drug conjugates in ovarian cancer. Finally, on World Health Day, as we celebrate and reflect on advances in our field, we also look ahead. In countries with low Human Development Index, cervical cancer is predicted to continue to increase and be the most common gynecologic cancer the next 20 years. Whereas in countries with very high HDI, cervical cancer incidence will decrease and endometrial cancer incidences will continue to grow. Are we able to change these predicted trends? As much as these are exciting times regarding advances of therapeutics in gynecologic cancer, as physicians, we have to continue to do our best both to educate and influence decision makers to implement preventative measures such as screening and vaccination to minimize the global burden of disease and minimize disparities in gynecologic cancer care. Thank you.
Hello everyone, this is Yüksel Ürün. I am medical oncologist at Ankara University in Ankara, Turkey. Firstly, I would like to thank OncoAlert for its huge contribution to the Global Oncology Committee, and I am happy to be part of it. Today, I will summarize the latest developments regarding the genitourinary cancer. As you know, cancer continues to be a major global public health challenge for all of us. We face nearly 20 million new cases of the cancer and more than 10 million cancer-related deaths. And in the coming years, we predict the number will increase. Totally, GU cancer is responsible for 10% of this, and every year we see 2.5 million new GU cancers and 750,000 GU cancer-related death. Of course, prostate is responsible for most of new disease and the death, and testicular cancer is less. Fortunately, our cancer survival rates improved in last decades. For prostate, bladder, and kidney cancer, our oncological outcome improved more than average. And now for prostate cancer, our 5-year cancer survival is more than 90%. For bladder cancer is close to 80%, and for kidney cancer, more than 70%. Let's start with testicular cancer. And now we are in April, it's Testicular Cancer Awareness Month. Actually, testicular cancer, which is less common in this group, but our success in testicular tumor has been a model for solid tumors for several years. However, in addition to the need for more effective treatments, our primary goal also is to reduce treatment-related long-term toxicities. Prostate with lung cancer is most common cancer in men. Since the understanding of the role of androgen in disease pathogenesis in 1940s, especially in the last 2 decades, our treatment options have increased significantly. Now, this is the androgen synthesis, and for every aspect, for every level of this process, we have several inhibitor and several anti-hormonal agents like abiraterone, enzalutamide, darolutamide, and apalutamide. It start with, of course, it's not start in 2004, but our first agent to improve overall survival after androgen deprivation treatment is docetaxel, which is increase overall survival of patient with castrate-resistant disease. But nowadays, we have several other options beside hormonal treatment, new chemotherapy like cabazitaxel, even immunotherapy in selected patients, and of course, PARP inhibitor for patient with BRCA1, BRCA2 alteration. Urothelial cancer, also common tumor, especially in men, and chemotherapy has been our only option for many years in metastatic disease. However, most of our patients, let's say at least half of the patient, not fit enough for cisplatin. But today, besides the chemo, it's gratifying to have immunotherapies, targeted treatment that improve our survival of our patient. Now, after the chemotherapy, we have 5 different types of immunotherapy, like erdafitinib for FGFR mutation patient, and also enfortumab vedotin, which is antibody drug conjugate. It is no new option for our patient. Also, in last ASCO in 2020, maintenance avelumab showed improvement in overall survival of our patient. Kidney cancer, of course, the advances in kidney cancer is huge, and now we understand the pathogenesis of disease very well. Of course, I have to acknowledge Tony Shuari, my mentor, when talk about the kidney cancer. And of course, some of these works by William Kaelin and others researchers like Sir Peter Ratcliffe and Greg Semenza awarded with Nobel Prize for their discoveries of how cells sense and adapt to oxygen availability. In last 20 years, the survival of our patient improved very well. At the beginning of 2000s, the average survival was around 1 year, but today we have more than 4-year median overall survival for patients with kidney cancer, and we have several treatment options. Not only monotherapy, but also several combination treatment is available for our patient. Let's say, give one example. This is the Nivo plus Ipi combination, and the final update was presented with Laurence Albigis, and 4 years survival is more than 50%, and still median overall survival not reached. Of course, we have several improvements in many type of cancer, but challenges also we have several challenges to overcome. One of the most important thing, I think, equitable access to medical care is for global health is very, very important. Also, still we do not have predictive biomarkers for response and resistance to treatment, and we do not have predictive biomarkers for daily clinical practice. Of course, optimized care for older adults is one of the challenges we should overcome in the coming days. Thank you very much for watching me. Thank you. Have a good day.
Thank you very much for joining us today, and don't forget to tune in tomorrow for our session on patient advocacy. From all of us at OncoAlert, happy World Health Day.